AGFA Healthcare, our modular platform is uniquely designed for you to manage control of the custody of images and information, whether it's the start of an episode of care, patient transfer from one facility to another, or the continued monitoring of treatment at home. Our enterprise imaging solution brings multimedia visual information into the patient's EHR for reference, for comparison, for value-based care. AGFA Healthcare brings people, systems, and information together to deliver care you can see.
Good afternoon. Welcome to this month's webinar, Enterprise Imaging Governance 2.0, a primer for the HIMSS-SIIM community. In addition to the continued support from AGFA Healthcare, this month's webinar has been developed in conjunction with the HIMSS-SIIM Enterprise Imaging community. I'm Lawrence Ngo, resident physician at Duke University Medical Center. I have the pleasure of serving as a moderator for today's session. We are privileged to have with us today Dr. Chris Roth, Vice Chair of Information and Technology and Clinical Informatics and Director of Imaging Informatics Strategy for Duke University Medical Center. In addition to being a neuroradiologist, Dr. Roth has chaired or co-chaired Enterprise Imaging Governance at Duke Health since 2012, which involves image storage across all image specialties, clinical decision support, image exchange, and electronic health record clinical workflow and data flow. His unique balance of clinical, informatics, technology, and business expertise has shaped him into a perfect advocate for enterprise imaging, making him an invaluable leader and co-chair of the HIMSS-SIIM Enterprise Imaging community. After the presentation, we'll be engaging in a Q&A session. Be sure to engage through the chat window at the bottom of the webinar control panel. Let's begin the presentation. Welcome, Dr. Chris Roth.
Thanks, Lawrence, and welcome everyone to the October HIMSS-SIIM webinar. Governance is a routine topic at both HIMSS and SIIM annual meetings, and it goes without saying that it needs to be done well by this point. If you're on this webinar, you care enough to be here and understand that. That said, governance isn't a common cocktail party topic. Most people's responses when discussing governance is to yawn or worry about sexier topics like machine learning or population health. To me, governance has a lot of overlaps with strategic planning and leadership, and ultimately is to me an indicator of the effectiveness of your healthcare organization. We're fortunate this month with the webinar that we've been able to invite HIMSS members, and this is the first time we're going to have folks that are largely outside of imaging that have registered for this webinar, and there are a number of you on this webinar, and I welcome you to your first engagement in many cases with the Society for Imaging Informatics. So what we're going to start with is an introduction to imaging governance. SIIM has been looking at this a lot, and I want to make sure we all start off at relatively the same level. We're going to talk about what makes governing imaging different than governing the EHR. The SIIM folks know this already because we've talked about it, but imaging governance is fundamentally different than governing an EHR. And this will give some tips to not just the HIMSS folks, but also the SIIM folks for how to integrate your EHR governance with your imaging governance and how to communicate with your CMO, CMIO, CIO, how to best design your imaging governance. And then finally, we're going to talk about how your governance will morph and evolve over time. Ours has done that, and the other sort of pioneer institutions that are doing enterprise imaging have also indicated and shown in prior SIIM annual meetings that your governance changes depending on what it is you're trying to do at any given time. So we're going to talk about sort of a 1.0 version of governance and then move into things like population health and price transparency, new issues like how to measure performance and machine learning and some other things as well. Before that, I want to thank both the HIMSS and SIIM societies for the collaboration that's happened between us to merge knowledge bases together. And these are the folks that have helped to make it happen. These are the folks that are guiding the relaunch of the HIMSS-SIIM enterprise imaging community. And in coming weeks, you'll hear more about the reboot, which will include other things like HIMSS and SIIM joint content development and education, and a website refresh that is beginning to take shape now. If you're struggling with your governance design or implementation, whether it's EHR governance or imaging governance, the HIMSS website offers some good articles and presentations that I've used in my own designs here at Duke. The resources aren't imaging specific, but instead focus in many cases broadly on good healthcare governance design, or if you're very focused on imaging, in many cases it'll talk about the linkages necessary to the electronic health record or to metadata and getting them to the downstream repositories that you can use for business intelligence. SIIM, as I referred to earlier, has been talking about and presenting on imaging governance at our annual meeting for years now, oftentimes more than once at our annual meeting. And we've talked about not just the varied specialties and workflows involved that you're going to hear about over the course of this talk, but also important aspects of successful governance, looking at it from 30,000 feet, like focusing on strategic thinking instead of minutiae, managing complexity, determining your own risk tolerance, how to inject systems thinking and determining when to innovate, when to be bold while you're navigating uncertainty. And while we've never focused an entire 45-minute monthly webinar on governance at SIIM, we have touched on it more than once in our webinars. I personally touched on it a bunch during my strategic planning webinar in 2016. For those that may be unfamiliar on the HIMSS side, there were a series of Journal of Digital Imaging white papers developed in 2016 by what has now developed into the HIMSS-SIIM community. And one of these did focus on imaging governance. There are a series of papers that you can find supplemental workflow and technology information in addition to that one. And we'll be posting information on how to find those later in this session. When it comes to the specialties that I'm talking about, there are obviously two large imaging specialties when it comes to data storage. Radiology and cardiology single copy at my organization are more than 700 terabytes of data, and that is more than 10 times larger than the single copy size of our electronic health record. And not only is imaging a larger component than our EHR of the total data that we have, but it's also accelerating faster. Whole slide pathology and genomics are very large imaging data lifts for any organization. The US is slightly behind Europe and Asia on whole slide because of the slowness of FDA 510K clearance. But realistically, and eventually, a third big data imaging specialty of pathology will be almost guaranteed. Imaging data is also visible light, still images, and video, and there is a lot of complexity around the workflows and the technology and the strategic planning with dealing with all of those. The amount of data is not very large compared to the big specialties year over year, but the complexity with respect to how do you implement it can be a large lift on the human resources in your organization. So all of a sudden, imaging governance has gone beyond just radiology, which is kind of the knee-jerk reaction. It becomes kind of sneaky, complex, rather expansive, with lots of specialties and lots of needs. Keeping the imaging specialties successful and efficient in their missions is plenty enough reason to care about imaging governance, but there are certainly others. Diagnostic imaging utilization is increasing across the country. Documentation type images via mobile phones and endoscopes are becoming more prevalent as the technology evolves. Every organization across the country is interested in cost cutting, no surprise. And while diagnostic studies today are a positive and strong revenue stream for almost all health systems, the equipment can be expensive. The systems to store and view the images are expensive. There are lots of FTEs in your organizations assigned to support these systems that in many cases don't play well together, as you'll see. And at many sites like mine that are taking on more population health and value-based care risk, the need to rein in utilization can oftentimes be at odds with one of the goals of enterprise imaging, which is making imaging technology more available throughout your enterprise. Add to those, many organizations are sitting on lots of potentially valuable imaging data for secondary use, either to do research on themselves if they're an academic site, or in partnering with machine learning industry colleagues. And having all the images in one place where it can be consumed and reused increasingly is a goal, whether you're at a research institution or not. One of the primary value propositions of enterprise imaging is security, and specifically integrating imaging pixel data and metadata into the EHR is critically important in this day and age. And sadly today, USBs and CDs are still too commonly utilized in many of our hospitals to move images from modalities to shared drives or to a workstation with an electronic health record, or worst case to a banker's box in the closet. Lots of these portable media are potentially not encrypted, at least occasionally some of the ones that we found at my organization. And hospitals, they're spending a lot of time on some of the advanced security efforts that all of us have: multi-factor authentication, desktop virtualization, penetration testing, etc. And something as simple as routine clinical workflow that involves imaging remains a stubborn PHI risk that can really upset the apple cart for everybody. Finally, enterprise imaging governance matters because there are in many cases acute politics that exist between folks in our organization, maybe at least chilly relationships that can prevent people from talking or trusting. And that can get in the way of some of the pop health initiatives that we're going to talk about later in this conversation. Maybe some of the bigger imaging specialties at your site don't consider this much of an issue because they're still fee for service, they're still doing fine. And in many ways, they're to be understood for having that sort of narrow, near-term perspective. The smaller specialties, in many cases, stand to gain more by democratizing these systems. So the smaller specialties are very interested in enterprise imaging governance, while the larger ones, in many cases, may be interested in just keeping current state, because the bigger specialties may not get as much value out of enterprise imaging as what the smaller ones do, as you'll see later. So, for example, growing and supporting point of care ultrasound, for example, takes away business from radiologists and cardiologists. Giving up a relative monopoly of a centralized archive can be anxiety provoking. And we have to get to a point where collaboration is the effort and trying to break away some of these chilly relationships. I think at this point, none of us have the luxury to not pay attention to imaging governance. And imaging is an important extension of the electronic health record, and anything imaging needs to be treated with the same level of attention that the electronic health record gets. Imaging governance is different in a number of ways that I'm going to talk about that have implications for how you design your imaging governance. Many C-suite providers in the hospital and in IT come at imaging governance from the perspective of come at imaging governance from the perspective of their EHR governance, and in that way it seems intuitive because they have an EHR governance that works. The providers understand and routinely use the EHR, and anything imaging would somehow, in some ways, have to fit within an existing EHR governance structure. Imaging can be a black box to the IT and operational C-suite, and if you're in imaging at all today, you probably recognize the black box play on words, because in many diagnostic imaging specialties, whether radiology or cardiology MRI or OB ultrasound, the rooms are literally dark and slightly intimidating to walk into. They make for really good spaces to find subtle black, gray, white differences in DICOM images to make them viewable to the human eye. But they are, in many cases, literal black boxes. And most of you, if you're on the CIIM side at least, have heard that enterprise imaging does not equal radiology. We've talked about that a lot, and we've talked about some of the other specialties. Most of radiology reading rooms are not like the ones you're going to find here on the first page of Google. They're much less cool looking. They kind of look like this straight out of my institution earlier this week. So literal black boxes, they also, more importantly, are figurative black boxes to physicians and most in IT, because most of them never spend dedicated time, or at least lots of them never spend dedicated time in imaging heavy specialties. Typically, imaging areas aren't required rotations in medical school. At Duke, radiology is a required rotation to graduate medical school, but that is the exception. Most medical schools do not have radiology as a required rotation. And in many cases, when you're in medical school, you're not spending time in the cath lab, you're not spending time doing OB ultrasound, you're doing more bread and butter type work on service. So most physicians and most in IT don't get a lot of exposure to how imaging works operationally, much less the technology or informatics behind it. Recall, obviously, that most C-suite physicians, providers, are internal medicine, ED, family practice, anesthesia, traditionally either non-imaging specialties or specialties that do little of their own image generation. With that in mind, the governance that you're going to bring to your organization, the physicians that you're governing, you're working with docs that don't have a lot of exposure to the technology or to the communication standards between components. If you're talking to CMIOs and many in CIIM, I've learned many of our direct bosses need context on why imaging governance is complex or why it's different than EHR governance, because they don't have the imaging background. They're interested in helping us strengthen our imaging governance, but they need context on how to do that. So the next slides should give us a little bit more information on how to do that. Let's start with an obvious one. The EHR is primarily HL7 structured and unstructured text. Yes, there are scan documents, but those are pretty simple to deal with compared to DICOM, diagnostic studies, video, mobile imaging. Imaging governance is primarily pixels, but it's also associated imaging metadata. Maybe DICOM or non-DICOM. If it's DICOM, you have to pay attention not just to the data, but the transmission standards. For example, the scanner to the storage to the viewer. And then obviously it is also HL7, structured and unstructured text. Some workflows in imaging governance are scalable across sites. In many cases, that's not all of them. Don't ask a dermatologist to do exactly what a radiologist does to get images stored. It's just not going to work, and realistically shouldn't be something that imaging governance imposes. So some of what the goal of imaging governance in the beginning and really throughout its maturation is to grow the clinical and IT leadership and governance member literacy of clinical workflow and data flow for imaging. And how to do that is engage with CIIM, call other sites. You've all got friends at other sites that are doing some of this work. They're good spies to have. Make sure you get information from them on how they're doing various workflows and data flows, because sometimes, learning from others, we just move a lot faster that way. Over the course of this webinar, you're going to see some green texts and checkboxes at the bottom of my slides. These are some of the recommendations that I want to be sure everyone on this considers with respect to the imaging governance 1.0, blocking and tackling, the easy stuff. Let me rephrase that, not the easy stuff, the stuff you certainly need to do first. And this growing your knowledge base applies to both data and also the black box considerations from the prior slide. Integrations. So the EHR is a single vendor. It generally works with itself. And there are relatively few EHRs out there. And what that means is those EHRs have had dozens of thought-leading organizations building smarts into their model or foundation system for years. And out of the box, you get all of that smarts when you turn on an EHR. With imaging, it doesn't work that way. So your EHR in most cases does not include best of breed imaging components. For example, none of the big EHRs make modalities. They may have viewers that may be sort of primarily made for one or two specialties, but may not be ideal for an entire enterprise. They may not have some of the components that you already have in your organization today. And even if there are imaging components available as part of an EHR vendor portfolio, it may not be one that you want. Just because a system has something doesn't mean it does it well. It's not necessarily usable by the folks that would have to use it. Thus, almost all of us are left integrating downstreams into the EHR rather than governing the EHR itself. There are lots of inherently vended components to string together: archives, viewers, very different modalities when you consider scopes versus phones versus DICOM radiology or cardiology. And they come from lots of vendors who typically don't have the footprint or the dozens of sites like EHRs do. They don't have as good of a parallel for an individual component, and you're having to link it up with lots of other things. There's a saying that those in HIMSS are familiar with, that seeing one EHR installation, you've seen exactly one EHR installation. In my experience, that's even more true in imaging, because so many of our sites are unique with respect to what our strategic goals are, and then also the technology that we deploy to try to meet them. So it's really a true case of designing the plane as we fly it. Each organization, when you start out with imaging governance, already has a lot of these components in place that may not be the place with an enterprise-wide electronic health record, where you're going to be starting essentially from scratch. And when you dig into the technical aspects of imaging, you learn that some of the shortcomings at the margins between the vended products can only be overcome with a lot of vendor collaboration between more than one, oftentimes 2 or 3 different vendors, or development of cross-organization standards or profiles, like what the integrating the healthcare enterprise does day to day. So one of the things that I recommend strongly is to bring your imaging teams closer together. When we went up on our EHR, the imaging teams were buried within the EHR governance structure and very separate from all of the other imaging teams that were there before it. At my institution, we have a shared enterprise imaging service. It's an IT team with representation from clinical engineering, who manages the modalities, the EHR, the viewer, the archiving team, project management, plus myself. And all of our imaging teams report up through a single director, with the exception of clinical engineering, so that they familiarize themselves. And this is new in about the last 6 to 9 months, because we found that imaging governance within the EHR governance was a struggle for us. We wanted to have the imaging parts of the EHR closer to the imaging parts of everything else, like the viewers and the archives and the scanners. So what we did was we changed the human resources hierarchy so they all report up together, and we actually physically moved teams. We physically moved the offices of the archiving and viewers teams from one building where they'd been for 15 years to another building where the EHR team works. And this has been a very successful thing for us, because all of a sudden people are interacting more frequently, they're getting to know each other better, we're having better work culture, and it's been a win for us. So bringing your teams together, I think is really important, and has been successful for us. No surprise with respect to integrations and governance is spend a lot of time investigating anything before you decide to buy it. A lot of the trouble you're going to have between the components can be addressed ahead of time, or perhaps at least burying it in contract language to make sure it gets addressed. And then finally, part of imaging governance is to engage your procurement hard and standardize. It's inherently part of the electronic health record to standardize, but that's not necessarily true with imaging right away. And you have to lift that to make progress on standardization. Cadence. So the large electronic health record companies recommend a cadence of upgrades for the best systems and actually provide discounts and minor rewards in some cases for having a high percentage of up-to-date functionality. They come through the door with a track record and expectations of change control and governance practices that create an internal cadence to improving their systems. The imaging governance companies don't necessarily require the most up-to-date systems like some of the EHR companies do. And they certainly care about institutional governance, but in my experience, that push by imaging companies is not as strong as what it is as the push that comes from the electronic health record companies. Visibility of the electronic health record almost without effort automatically creates a cadence as well, because annual or fiscal year, calendar year, expected job results, metrics for your leadership and staff, these create impetus. They create regular topics of conversation that create a rhythm for moving your electronic health record and the associated care given by the providers forward. Imaging is different in that there's certainly lots of opportunity, but it doesn't start with a defined rhythm, so you have to build that rhythm. What we did was with our imaging governance, we created a calendar that was clear and made 4 to 6 months in advance. And I'll talk to you about what the entries on that calendar were. What it did was it gave attendees something to look forward to be prepared for, to talk to their colleagues about, and get contributions from other members of their department. We started each imaging governance meeting with about 5 to 10 minutes of updates from the last meeting, and then we dug into a heavily strategic topic. So we started with image storage prioritization, enterprise viewing, image exchange, decision support, procurement standardization, the strategic plan, and these were one of these every month, and we dug into them. You may, if you're going to create, a cadence of highly, specific subjects, it may be something else that you want to talk about. It may be something like, we're going to do dermatology today. We're going to do mobile image capture next month, point of care ultrasound the month after, endoscopy the month after that. You may want to focus instead on the parts of your EI program. Finances today, data governance next month, technology the next month, clinical workflow the one after that. And these are important aspects to plan out, to give your imaging governance committee an idea for what you're going to be addressing, because that cadence isn't defined from the beginning. The second big difference is, if we're fair and honest, in many cases, the burning platforms in imaging are usually not as hot as the ones in the EHR. There are certainly some, right? The Protecting Access to Medicare Act, some of the developments in machine learning and payment reform, there are certainly some aspects of imaging that are burning platforms. But generally, those in the EHR are more pressing, more visible, and get automatically much more attention. So one of the things that we did, like I said, was we developed a series of highly focused strategic imaging governance meetings focusing on the big components, the big use cases of imaging: storage, viewing, exchange, decision support, procurement. We communicated a lot with our members and outside of the membership, and then we started prioritizing. And what we realized very quickly was we had a ton of work to do, more than the typical team can handle at once. And as you create the burning platform of all of the different aspects that you want to solve, like I talked about, you'll develop a very positive cadence as well and address some of the skepticism and the chilly relationships between the specialties. It's never comfortable to prioritize one specialty over another. It's never something anybody likes because we all have limited resources. But I wanted to provide ours. And some of you have seen this before. This is one that we've been using for coming up on 2 years with good success. This is the storage system that we use for prioritizing which sites are going to store their images first. And we developed it as a systematic system intentionally for 3 reasons. First of all, given the parameters and empowerment to make decisions, individuals are pretty good at making decisions that optimize resource utilization. You want to make it easy for your people to make decisions and take some of the pressure out of it, take some of the personalization out of it, so that people can rely on a system and not have to feel badly about deprioritizing a group. Second, the second reason that we did it this way, staff within an organization that have unresolved problems need to know that their burning platform is not the only one, and they're not being deprioritized because you don't like them. So the first one was to make life easier on your people. The second one is to assuage the concerns of folks in your organization. Having a transparent scoring system, I think, prevents a lot of loud voices and backdoor attempts to subvert the committee and try to get stuff done. You know, the hit up in Starbucks or in corridors or just before another meeting is for real. Hey, can I get you a coffee? I got to talk to you about something. You know, having a system like this prevents some of those kind of approaches. Thirdly and lastly, it gets the unprioritized folks thinking about how to productively elevate their own priority. And one way I've seen an unprioritized site bump themselves up was they went and started recruiting others like them, either other surgical areas, physical locations, talking to their own people, and they started recruiting and changing their own culture and making themselves actually more prepared from a cultural perspective to get in on what we were offering them. I've seen another where, you know, those sites are now aware that they have to deal with getting their technical infrastructure ready, like making sure that their devices are DICOM compatible, they have DICOM licenses, they have wireless, they have the things that they need. There are 11 categories. Anybody's free to look me up on Twitter and download this or take a screenshot of it and use it in your organization. 11 categories focused on security, revenue increases, annual cost savings or reduction, the value of image review by others in the organization. So we're talking about image storage here. How valuable is storing those images for others in the organization? What kind of workflow improvement might you find if we were to store these images? We've had some sites tell us that they're saving 2 hours a night after a clinic day because we've turned them on to a systematic method of storage. Research and publication value, teaching value, value of the images to patients, and then the cultural readiness, the technical readiness, and how much time is it going to take to do. How else is imaging governance different? So it's obviously, EHR governance is an inherently discrete, unambiguous entity. You know when you're talking to ER governance, you know when you're a part of ER governance. Imaging governance is a little different in that it might be a discrete, centralized entity, like what I just put up in the schematic in green, or it could be a decentralized, relatively infiltrated entity where specific imagers are part of the EHR committees on the line below. So imagers on radiology and cardiology and OB and dermatology and surgery who report up through the EHR governance. And just like the EHR spans multiple specialties and stakeholder groups, at our organization, Enterprise Imaging does the same and sits at the same level of our electronic health record. So one of the things I think is important here is to recognize how you want to develop your governance today. Make sure that fits with what you want to do in the future. And then whomever's on your committee, make sure you regularly recognize and thank them wherever they are. When you registered for the webinar, everybody took 2 questions and answered them that I found some interesting findings on. The first question was, when considering endoscopic video and still images, dermatology, and point-of-care ultrasound, how does your hospital govern capture, storage, and viewing? And it's split relatively evenly between distributed or centralized. But what I found was a lot of sites don't have any of the governance today, which leaves me a little discouraged. I think it's interesting. I think it's also encouraging that many folks who answered the question this way are on the call. So I don't think we're at a point that we can consider this optional anymore. The total registration for the webinar was 220 today. And if even, half of this 23% number is true, there's more than 20 healthcare institutions that are on this call that haven't begun an enterprise imaging program for these pretty important modalities. I don't think it's sustainable long term, and I'm happy to talk to any of you afterwards. The second question was, how happy are you? How well do you think your governance is working? And there are relatively few people who are really jacked, really excited about the performance of their governance. I think a high-performing governance takes a long time to create, and it probably also takes a long time to realize when you have one. There aren't many metrics that inform you that your governance is working great. There are metrics that inform you your EI initiative might be doing well, and we'll talk about those. My message to you, I guess, is if you feel like you're struggling, you're not the only one based off of this. Take heart and keep forging forward. Imaging governance is also different because of leadership. The ones who own it are a lot of times the ones on the Cadence slide who have the metrics assigned to them. The question comes up, who really owns this? In the EHR, you know who that is. It's the health system and existing leadership. In imaging, it's less obvious. Is it radiology or cardiology? They've got decades of lessons learned on archiving and organization and viewing and resulting. But in many cases, despite their long track record, they don't have a lot to gain or may have less to gain with, let's say, storage. They certainly have a lot with respect to clinical decision support or image exchange or improving some of the viewers. But with respect to storage, there may not be a whole lot that they're interested in. It may be too that the radiology group that you're working with has an archive that is not technically able to handle some of the data that might be sent to it. So if you try to leverage the PACS system that radiology or cardiology uses, it may be that it doesn't do non-DICOM from dermatology. It may not be able to handle movie clips. And there can be some questions around ownership and a number of other things. So who owns imaging governance can be hard. You might ask if a smaller specialty could do it. In many cases, they don't have, despite great interest, a ton of resources or experience doing it. So keeping in mind who owns it, I think it's important to identify and support and fund the engaged leadership to make sure that your imaging governance is successful. Do your best to find creative and mutually beneficial arrangements to participate as well. So pooling resources for new stuff or support staff, offering contract extensions with formalized governance buy-in. If radiology or cardiology are not interested, you can find creative ways to make sure they're interested. Finally, strategy. EHR governance, the common strategy we hear is one patient, one record. In imaging, it can be a little harder to boil it down. This is the guiding principle that we have for Duke Health imaging governance, which is all clinical multimedia with relevant imaging metadata, name, MRN, date, encounter, anatomy, modality, and result will be accessible in the chart. I think it's really important for everybody to have an on-paper circulated strategy really early, because again, it begins to address culture change and skepticism and defining your metric. It helps call out some of the politics. It helps you identify where to start as well. If everybody's complaining about the same thing, it becomes easy to identify that as an early initiative to go after. And it gives you a jump on developing the RFPs and policy statements you're going to need. Finally, make sure those that are on imaging governance contribute to non-imaging strategies as well. I'm referring to pop health, business intelligence, analytics, access, revenue, research, other things. I'm not going to get into the details of how we did our strategy. If you're interested, you can still go on the CIIM website and find the webinar that I did in 2016. This is our structure, and this is an example of one of the specific initiatives around our enterprise viewer. Again, if you're interested, I would refer you to the webinar that's already available. So 1.0, just to summarize, get everyone on board, and this is the list of everyone you want to make sure you've got. Get a documented strategy and push ahead. 2.0. Let's talk about 2.0. First of all, before we get into 2.0, make sure you're really good at 1.0. Typically with 1.0, there's some inciting event that required the governance that brought everyone together. A hospital or health system buys an EHR, a merger and acquisition happens. Somebody wants to buy a new PACS, something like that. You need to address, as your imaging governance evolves, I'm going to talk about three things that I think are particularly important. One is what your governance needs to do. In my opinion, later aspects of governance, more mature aspects of imaging governance grow higher level and more strategic. It'll become more anticipatory after the exciting event that it brought everyone together has been addressed. Your champions are in place, you've got design resources, you can point to people in their specialty. Imaging is recognized as an important thing to consider. It becomes higher level of where do you want to go for imaging in your organization. Second is new issues. Just because you start an enterprise imaging endeavor doesn't mean the rest of your organization is going to wait for you. They're going to keep forging ahead on new things. And finally, performance measurement. Just very quickly, the governance evolution you're going to find is things are going to start rolling, and you're going to start improving all the different aspects of imaging, viewing and archiving and exchange, etc. Your hospital may keep growing, it'll keep consolidating, it'll do all the things that hospitals are doing today, it'll keep improving all of the care that it provides. I think it is really important, and this is something we've tried to do at Duke, is make imaging governance a mindset. Make it something that people recognize, just like EHR governance. Make sure you have a strategy that's available that you can talk to. Make sure you have a process that you can point to when necessary, and set the course for your organization. And doing that, in many cases, is more valuable than meeting. Meetings are good, get everybody together, there's a culture win there. It keeps everybody accountable. But more than that, you want to develop a mindset, a culture in your organization, and push it down to all the nooks and crannies of your organization that you can turn governing of the team over to the team itself. There's a level of self-discipline to put in here around imaging governance, that you want to be sure people in your organization recognize that there's governance and govern themselves. If you're on this call, you're an imaging governance leader. You can't be everywhere. You need to have champions and teammates that can message for you and really push it down to other parts of your organization to solve problems before they get to a governance level or the C-suite or other places. Occasionally, you want to revisit the form and makeup of your committee as well. I would say that some governances will grow more centralized. Mayo Clinics has done that in my experience talking with them. Duke's has probably gotten a little bit less centralized, and we're pushing out our governance to local areas and local specialties. There are procedures and expectations and policies that everybody has to adhere to, but we want to make sure that governance is light and addressed at the local level wherever it can be. Payment reform. In fee-for-service, like we talked about, there are some specialties that win really strong. There are some that aren't as big of winners. And when we started off with imaging governance, we were focused on compliance and security and strategy, not so much dollars. Costs were deployed out like plumbing or electricity. It was just the cost of doing business. As we get further and further away from that and less focused on fee-for-service, more focused on population health, we're growing more attentive to how dollars move internal to my organization and also leaving my organization. And as I said earlier, what's happened is as you historically not having a storage or viewer was a significant barrier to entry for the outlying clinics or the less frequently imaging specialties. As you take away these barriers by deploying an EHR and deploying your EI strategies, those sites are going to become more and more interested to image themselves. Enter population health. So let's talk about this. And if you've fallen asleep, because this is governance, I would ask you to wake up and let's really think about this for the next 5 minutes or so. Under the final 2019 CMS inpatient prospective payment rule, hospitals are required to publish a list of their standard charges online in a machine readable format, okay, XML, not PDF, not Excel spreadsheet, and to update this information annually. Hospitals are required to make this info publicly available currently or available upon request. The direction that CMS is laying out is we want transparency. We want patients to know what different services are going to cost. Now, this is inpatients we're talking about, but you can see this going for outpatients eventually. The public is going to start comparison shopping based on price as early as next year. And you may have several groups in your organization that are performing similar procedures but charge differently, right? Lots of groups are doing carotid ultrasound or venous ultrasound. Lots of groups are doing radiography, and they may be charging different things. At a minimum, I can imagine, and we started to think about this a little bit here, the enterprise imaging group is going to get engaged to support those specialties that are performing the highest quality internal care services at the lowest price. Okay, that's what your prioritization is going to be also. Your organizations are going to want you to support the strongest, most favorable use cases for enterprise imaging in your organization on the basis of cost and quality. A second one is patient engagement. So enterprise imaging services and initiatives that make your organization stand out from competitors outside your organization will be critical. You have to win the comparison shopping game. And those items for enterprise imaging that help an organization do that are going to be the ones that get prioritized, right? This might be something like making full imaging studies available in your patient portal. And we've started briefly already down the road to doing that. The third one is referrer engagement in pop health and imaging governance. So in capitated at-risk models of reimbursement, imagers who don't own patient care are going to want to engage the referrers for the same reason as they would for patient engagement. They need to be able to market their services within their own organization, and they need to comply, for example, with the clinical decision support mandate from 2014 to ensure that the right study is done the first time. Imagers then become, almost automatically have to become much better stewards of the services and dollars spent, because hospitals and health systems are going to want to feed the population health winners, the doctors and imaging services that are the most successful, and your enterprise imaging governance is going to be expected to support that strategy of your organization and make sure that the people and initiatives are focused on the things that matter the most to pop health. As I said before, when we started this, we were focused a lot on getting the system right. We weren't focused as much on individual costs, but we are looking at per unit costs for any group that wants to add a new piece of software, a new modality, something like that, and make sure that it is performing well. There's just more oversight happening today. And then care optimization. No surprise, everybody wants to be sure that with public data available for costs and quality, that we're doing the best we can. If you want to know more, we're going to be talking about this in CIIM 2019 in June in Denver, where we're going to talk about some of the thornier issues. It's going to be Cheryl Pettersilge from Cleveland Clinic and myself. You want to be able to address new technology as well. Generally, the least expensive way to do that is to use your EHR when possible, or use another system that already has that capability. And we at Duke and most other sites are taking very aggressive approaches to focusing very early on the evaluation process of new technology and controlling the messaging. Even so far at my place, for if you're going to bring a demo system in for what we call an informal look, there has to be stakeholder group or imaging governance committee engagement to make sure everybody is involved in this. Finally, 2 slides. The group, the imaging governance group, is going to be interested in checking itself and seeing how well it's doing. Obviously, you want to measure, it's more important to measure the performance of your organization than it is to measure the performance of your governance. We looked at some governance metrics specifically, but it took a lot of time to do that. So we focused more on how is our enterprise imaging initiative going. And if you think about what are the things you want to measure, there are almost a balanced scorecard worth of metrics to consider. And this is another one that I put on Twitter earlier today. You can certainly take a screenshot and we can talk about it. But you can build up a balanced scorecard of clinical quality and security, HR finance, or research, depending on your organization, the specific things you might want to track. And digging into that is something that is worth doing in your organization, so you understand, and other people in your organization understand that what you're doing is important, how much work you have to do, and the value of what you provide. Finally, we at Duke measure our enterprise imaging initiatives through the HIMSS-SIIM. As of today, this is run out of HIMSS Europe. And you're going to be hearing from my esteemed and overworked HIMSS-SIIM community co-chair Kim Garriott in the near future around the revisions to the DIAM, and I'm looking forward to them. Your leadership in IT and operations may not know much about imaging because it isn't their day job, but they, I'm sure, know a lot about HIMSS analytics adoption models, because a lot of them have already taken the EMR model or the analytics model or applied for the Davies Award. The way this works is you take a survey that asks you questions across a broad spectrum of infrastructure, workflow, process, the nature of your organization. You submit it back to HIMSS and they tell you how you're doing. And the existing model is relatively tilted towards radiology, but again is going to be updated in the very near future and it will be focused much less, or at least across many more specialties than just radiology. When we first took this, I'm not allowed to share the questions, I'm not allowed to share our results, but I'll say that almost 2 years ago when we took this, we graded out as a stage 4, and the maximum stage they'd given out at that point was a stage 5 to a European organization. And we struggled in a lot of areas that American imaging organizations do: clinical decision support, structured imaging, result data capture, our local health information exchange, imaging analytics. We had handled all the stage 4 down stuff like archives and viewers and workflows. But what this has helped me do is message to my governance and my boss, my leadership, the feedback from this report so that we can start addressing the infrastructure and process gaps so that we can grow as an organization. I found this to be very valuable, and I'd encourage any of you to take a look at it. This slide is the summary of all of the recommendations that I gave earlier in this conversations. You're welcome to take a screenshot of it for a second. And with that, I will turn it back over to Lawrence No and the organizers. I think we have a minute or two for questions. I'm happy to stay on as long as I need to.
All right, thank you, Dr. Roth. We'll be now moving to the Q&A portion of the webinar. During this portion of the webinar, you may ask questions via the chat window at the bottom of the webinar control panel. So we have a question here from Bruce Levy. He asks, how do you deal with scanned documents? Are they part of your governance plan?
We at Duke do not consider scanned documents within enterprise imaging governance. A lot of groups do, a lot of organizations do, a lot of vendors do. We kept our scanned documents in our health information management department and let them do it. But again, this is very local, depending on how your organization wants to do it. And I'm not sure there's one right way, as long as you adhere to the right principles.
And I understand we also in radiology probably try to digitize a lot of the scanned documents at least, so that it does become part of under the governance. Is that correct?
It does. If it goes into a radiology system or an imaging system, if we icomize a screening form or something like that, that is something that would fall in either to the radiology stakeholder group individually, or if necessary, a higher group. But there's certainly, most of our paperwork, if you will, goes through the health information management here at my institution, at least.
All right. Well, I think we're right at the hour here and out of time. So the HIMSS-SIIM enterprise imaging community is consistently working to improve and advocate and educate the healthcare community on the value of enterprise imaging, as well as best practices for successful implementation. The community is a revolving membership door and is open to any member of the SIIM and or HIMSS community. So you can visit bit.ly/enterprise imaging community for more information and to join. I guess I'll pause just for a second here because we do have just a couple more questions coming in, and just see, I think we can just perhaps address one more here.
Sure.
Yeah, so regardless, so there's a question from Brad Levin. He's asking, regardless of whether a centralized or decentralized governing model is deployed, do you believe there perhaps could be a missing ingredient, i.e. a new position that could be implemented within an organization? For example, a clinical director of enterprise imaging or reporting up to the C-level.
I think every organization is going to do that differently. So I'm a physician, I'm a neuroradiologist by training. If you ask my neuroradiology colleagues, they would say I'm in IT. I spend a lot of time as somebody, talking directly to one of my bosses, which is my CMIO, as a physician, specifically around the physician needs in imaging. We also have directors and coordinators that handle enterprise imaging, and it becomes a local decision of, do you want to consider enterprise imaging as another big third specialty? And we've wrestled with this at Duke. There's radiology, there's cardiology. Do you lump everybody else into enterprise? Do you, and then set up, a hierarchy where there's a specific director for enterprise, a specific reporting setup where the enterprise reports up to the CMIO. I think that's a very local decision based on the goals of your organization, how big your organization is, how mature you are in terms of connecting up. I think it's a reasonable question to ask that we struggled with ourselves. We feel pretty comfortable with it set up today, where I, as a physician, can, on behalf of governance, on behalf of the physician, speak directly to my CMIO and CMO about such things. And I believe our coordinators and directors can as well.
Great. And actually, there's just one more question here. How is governance funded?
So governance is an expensive proposition, right? So we at Duke, when we started this, we have 27 docs on our imaging governance group. Okay, that's not the EHR governance. And in many cases, some of us were funded. I was funded to do that work as the co-chair and chair of that. Some of the other folks, they were not funded. It was just, they were identified as the person in radiation oncology or neurosurgery or orthopedics who cares the most about imaging. And in many cases, what you find is people that go into the quote less imaging or non-imaging specialties, they went in for a reason. They're not that interested in image production. There are a select few who maybe they've got a point of care ultrasound, maybe they're technologically inclined, maybe they're administratively inclined, and they want to see care improve. We tried to engage those people in some ways because we didn't have to fund them. They would be interested in making care better. They tended to be younger and more aggressive, and they were interested to be part of leadership. So if you have to fund people, I think it's necessary in some cases too. If for no other reason than, one, making sure you buy enough of their time to do the work well, but two, so that there's a level of expectation on the person that you're paying that they're going to not be provincial and not only care for their own stuff, not only care for whatever specialty they're coming from. They are recognized as somebody who will address lots of people's needs because they're getting funded time for it.
All right. Well, thanks again, Dr. Roth. We had one person just point out that that bit.ly link I mentioned earlier is case sensitive. So again, it's bit.ly/enterprise imaging community, capital enterprise, E for enterprise, I for imaging, and C for community. We want to also thank, once again, thank AGFA Healthcare for their support for the 2018 SIIM webinar series. Please join us for next month's webinar, which will be Applications for Intelligent Clinical Workflows, presented by Don Cram and Matthew Hayes. Thank you again for joining us on today's webinar. All webinars will be archived shortly after the webinar date and made available to SIIM members under the events section of the SIIM website.